Hi everyone, my name is Kávási Sarolta, Beáta, and let me present to you the PhD topic of surgical aspects of colorectal cancer treatment. Few words about myself. I'm in my last year of surgery residency and finishing up my second year here at the CTM as a PhD student. I have my supervisor Szabolcs Abraham and my SMS Anett Ranc helping me on this journey. I have a vision of improving the immediate postoperative and quality of life of patients following colorectal cancer surgery with the mission of bringing the latest scientific data to clinical use in this particular field. For this, I have two specific goals. Let's start with my first project, which is entitled End-to-End Anastomosis Provides Similar Quality of Life Compared with Other Reconstructive Techniques 6 months following total mesorectal excision. As we all know, worldwide there's an estimated 1.8 million people diagnosed with colorectal cancer each year, from which more than 700,000 cases are rectal cancer cases only. In Hungary, there's around 10,000 cases of colorectal cancer diagnosed each year. Anastomotic leakage, the most feared postoperative morbidity, is reported to be around 13% following 30 days of surgery, and it can increase up to 20% beyond 30 days postoperatively. Up to 90% of our patients undergoing total mesorectal excision might develop low anterior resection syndrome, which in turn will impair their quality of life on the long term. At this point, there's no clear consensus on which type of anastomosis is safer for a surgeon to perform. Thus, the aim of our study is to investigate which type of anastomosis is best in terms of safety and quality of life, and to assess if end-to-end anastomosis is as safe as the other types of anastomosis. For this, we have the clinical question of does end-to-end anastomosis show any difference in terms of postoperative morbidity and quality of life compared to other types of anastomosis? We have used the PICO framework, where we have patients following total mesorectal excision and comparing end-to-end anastomosis to side-to-end and colonic J pouch. We have our primary outcomes, which is anastomotic leakage, mortality, and long-term quality of life scores. We hypothesize that end-to-end anastomosis is as good as other types of anastomosis in terms of safety and quality of life. We have done our systematic search on the 8th of November 2022, and after a careful search and selection process, we have narrowed it down to 29 full-text randomized controlled trials. So let's talk a bit about my most important findings. First of all, anastomotic leakage is a very important outcome for a surgeon because, as I've mentioned, it is the most feared and most serious postoperative morbidity, and actually it is the most expensive one to treat. In this plot, we have the risk of developing anastomotic leakage comparing patients following end-to-end anastomosis to colonic J pouch. We have included 15 randomized controlled trials, and we used the measure of effect of risk ratio, which in this case was 1.03, meaning that the risk of developing anastomotic leakage is equal between the two studied arms. Similarly, when we are comparing patients following end-to-end anastomosis and side-to-end anastomosis, we get a risk ratio of 1.19, meaning that the risk of developing anastomotic leakage is equal between the two studied arms. Patients following total mesorectal excision face a variety of dysfunctions, not only bowel dysfunctions, but urinary, sexual, and even psychological ones. So it is very important to shift our perspective to the overall well-being and quality of life of our patients following surgery. As you can see, we have here a summary plot where we have checked our patients in 6 time points. Because of the varied questionnaire used to assess this outcome, we have used the standardized mean difference as a measure of effect, and actual statistical analysis was done at 6 and 12 months from 4 randomized controlled trials. At 6 months following surgery, the standardized mean difference was minus 0.22, and at 12 months, minus 0.24. Both are non-significant results, meaning that the quality of life is similar between the two studied arms. Similarly, if we are comparing patients following end-to-end anastomosis and side-to-end anastomosis, at 6 months mark, we can see that the SMD is minus 0.04, meaning that there's no difference in the quality of life compared between the two studied arms. So one might ask, what is the clinical implication of all of these non-significant results? Well, actually, colonic J pouch and side-to-end anastomosis are a bit they're technically challenging and time-consuming procedures, oftentimes requiring the usage of more surgical staplers. So if they don't add any extra benefit, then taking into consideration the socio-economic perspective also, we should use the end-to-end anastomosis. Some of our strength is that we have followed a rigorous methodology, included only randomized controlled trials in our analysis, and it is indeed the first quantitative analysis on the quality of life of patients following total mesorectal excision. Of course, the limitations is the lacking data on the side-to-end anastomosis and also on the long-term follow-up. As a conclusion, we can say that there's no difference in short-term postoperative morbidity between the 3 studied arms, and at 6 months, the quality of life of our patients following end-to-end is similar as after colonic J-pouch and side-to-end anastomosis. This is our progress. Unfortunately, it has been rejected by many journals, but hopefully it will be published soon. So on to our next topic, which is comparing surgical and oncological outcomes of extralevator to conventional abdominoperineal excision for low rectal cancer. So for advanced low rectal cancer, we all know that abdominoperineal excision is one of the standard surgical procedures, but unfortunately it carries a high risk of local recurrence, even up to a third. In 2007, Holm et al. proposed the ELAP, which is the extralevator abdominoperineal excision, where we don't only remove the rectum and mesorectum, but also the surrounding levator muscles, thus leading to a better oncological outcome. Of course, this also carries its downfall with an increased perineal wound healing and the perineal hernia up to even 60% by some studies. Thus, the aim of our study is to compare the morbidity and long-term effects of ELAP to APE. We have the clinical question of, is ELAP associated with an increased overall survival rate and higher morbidity compared to APE in patients with advanced low rectum cancer? We have yet again used the PICO framework, where we have adults with advanced low rectum cancer comparing ELAP procedure to APE. And the most important outcomes, the primary outcomes, we decided to use the overall survival, disease-free survival, and local recurrence-free survival, which are the long-term oncological outcomes. And we hypothesized that ELAP is associated with an increased survival time, but higher morbidity compared to APE. We have done our systematic search last year on the 14th of April, and after a careful search and selection process, we have narrowed it down to 36 articles. And this is where we are standing now. We are doing the risk of bias assessment at the moment, and we have received some preliminary result, which I would like to share with you now. First of all, the intraoperative perforation rate, it's a very important outcome to talk about because it is associated with a decreased long-term survival and an increased local recurrence rate. So in this analysis, we have included 22 studies, from which 4 were randomized controlled trials. We have used the measure effect of odds ratio, and as you can see here, we have an odds ratio of 0.52, which is not only clinically relevant, but also statistically significant result. If we move on, we have done a subgroup analysis on just the randomized control studies, and you see a more pronounced odds ratio of 0.22, which means that when considering only the highest quality evidence from randomized control trials, ELAP is favored over APE in reducing the odds of intraoperative perforation. Another important outcome we can talk about is the circumferential resection margin. In this analysis, we have included 25 studies, from which 4 are randomized controlled trials, and we have used the measure of effect of odds ratio. As you can see, our odds ratio is 0.66, and while we see a tendency of favoring the ELAP, unfortunately, our confidence interval touches the line of null effect, so we cannot say statistically that there is a difference. However, when we do a subgroup analysis of the 4 studies that have our randomized controlled trials, we see the odds ratio of 0.16, which is already a statistically significant result. So we can say that even regarding the positive CRM, extralevator abdominoperineal excision is favored over the standard abdominoperineal excision. At this point, we are awaiting still results from our statistician regarding the hardest outcomes that we have, the long-term oncological ones, and let's hope that we can prove that ELAP is indeed associated with an increased overall survival time and a decreased local recurrence rate. So in summary, these are my 2 projects. The first one hopefully will be accepted soon, and the second one I want to finish by September. Some of my additional activities, I have been to multiple international congresses where I could present the findings of our first project, and also I was a co-investigator in the one published article. And I want to thank you for your attention with my favorite quote, which is, "It is not the strongest of the species that survive, nor the most intelligent. It is the one most adaptable to change." Thank you.
So, are there questions from the group? regarding the first project, why the surgeons elaborated the more complicated surgery, the more complicated anastomosis, if the results are very similar? They were hoping, I guess, better outcomes,
yes.
right? But
So
what would be the idea behind the better outcome?
The idea is that if we have an end-to-end anastomosis and it's very low, like 3-4 centimeters or right above the sphincter, then there's a phase of like 6 months, but previous studies said 12 to 18 months that the patient has diarrhea and cannot control their stool. So they were hoping that by making a pouch, for example, a colonic J pouch, even though it is more complicated to do, it can be like a reservoir, like the rectum, because the rectum is excised, so there is no place where has the function as a reservoir. So yeah, that was their idea first, because these patients were suffering. I said that a lot of patients develop low anterior resection syndrome, which is also the same, that they have problems with their bowels, they have at night bowels, they have diarrhea, they have flatus. So this is what they were trying to make better. But interestingly, obviously I didn't have enough time to bring all the plots, but we have a leave one out analysis where if we remove one of the studies, there is a statistically significant higher chance of postoperative ileus after colonic J pouch, because that's the other side of the problem, that if you make a pouch, then the stool will not will stay there too long. And so yeah, that's the answer to your question, that they wanted to manage the diarrhea. And actually our study also proved, I couldn't show the bowel function measurements, but we proved that after 6 months it's already not different between the different types of anastomosis. Previously they said that you need 1 year or 18 months for your stool to become normal, but our study proved that actually even 6 months it's enough.
So you said in your first study, one result is that the complication rate is the same, right?
Yes, the postoperative morbidity.
Yes, there's no anastomosis leak is also the same between the end-to-end anastomosis to the others?
I'm gonna go back. Yeah, this is the anastomotic leakage rate.
It's
the same.
It's the same, okay.
But this is the most important one. Obviously, we have checked the mortality also, the postoperative ileus, overall complication rate, reoperation, and everywhere there was no statistically significant result. Only if we exclude one study, then there might be a higher chance of ileus in the colonic J pouch group. That's all the difference.
What is your coming back to the results? What is your consequence? You prefer an end-to-end anastomosis?
Yes.
Because it's the same
yes,
result?
Yes, it's easy, faster, easier. Yes. And the 6 months after surgery, I don't think it's such a long time for the patient to really suffer from the LARS. So if it would be that, yes, after 2-3 years only their bowel function returned to normal, I would say, yes, okay, we might consider making a pouch or maybe at least a side-to-end anastomosis. But 6 months, I don't believe it's such a long time for it to be worth it.
Mm. In your study, so you both groups are comparable in terms of stoma?
Good question. Well, there's an easy and a not so easy answer to this. They're all randomized control trials, so they should somehow divide all the confounders that they are, known and unknown. Some studies had ileostoma for each patient. But the rest of the studies, they tried to balance it. So in the regards of ileostoma, it was quite balanced, the groups, honestly.
Can you show us your last slide about the future studies?
For the first or the last?
From the second. I was wondering about the local recurrence, if you compare the ELAB and the non-ELAB.
Yes.
And could you show that again? With the plots? Yeah. No,
which one? The PICO?
The local recurrence rate.
This? Or?
No, the results.
Because we only have the intraoperative perforation.
This one.
Okay, this is only intraoperative perforation.
Yeah.
Okay.
ELAB is a procedure with you remove more tissue.
Yes.
Okay, and you have a more have more known touch technique, but you also see a positive. You see in some studies an even higher incidence of intraoperative perforation in the ELAP group.
Yes.
What is your explanation for this?
I actually just looked at this yesterday by accident. So this Park et al. 2016, they were using ELAP for very bulky big tumors. So when you have bulky big tumors, then you can have intraoperative perforation for ELAP also. This is a bit of a problem of this analysis and this study, because they are not all randomized controlled trials. And one might say that surgeons use ELAP when there's a bulkier T4 tumor maybe. So you cannot really compare them. But
you described a bias right now.
Yes, there is a slight bias. We didn't yet directly checked it, but we know this will be a bias.
Can we go to your time-wise? You have the timeline of effects on the first study. Okay, so here you refer to this one as
Yes,
there is no
6
difference.
months, yeah.
But how about this and this and this? Because these are all, at least statistically, look to be significant.
They look-
Although, I mean, so does it mean anything? Or this is
Not
just
much.
a what?
So it's a very interesting plot. We have brought this because it's easier to see. The actual one is much more complicated because you can see the actual studies at each time point. So at 3 months and at 12 months, there's only one study. So that's why we cannot take any conclusion from it. But we didn't want to omit it because we want to report at each stage what's happening. And also, our statistician used multivariate analysis, and they have taken into consideration each time point. So for example, even though there is one study in the 3 months, the SMD and the result is a bit changed because it takes into consideration all the other possible results.
Yeah. I mean, that's important because, I mean, to interpret this, that's important that, because of the limited data, I mean, there are limitations. So
Yes.
even if you get some kind of statistically significant or seemingly significant difference, but we have to be kind of aware about this. And
Yes,
then look
exactly.
the whole stuff.
And that's why I mentioned only the 6 months, because that's where we have 3 studies at least. But yet,
Got it. Yeah. Okay, good.
You have shown, including in your first project, you included papers from 2002 and 3. The time frame you're analyzing is more than 20 years.
yes.
So, and there's a big, there's a huge development. Maybe
Yes.
for 20 years, 90% were done in open surgery. Now we do it minimally invasively.
Yes.
So, what's your idea? Has this an influence?
Well, wonderful question. We have actually checked our basic confounders, if you can call them confounders in the RCTs. So this was one of them, the way of the surgery. Was it open laparoscopic or robotic? But regarding anastomotic leakage, it doesn't bring any difference. But the other good question is that hand-sewn or stapled anastomosis, because the ones from 2000 or 1994, for sure they were hand-stapled, they were hand-sewn anastomosis, not stapled ones. So we were trying to get data out of this, and also we checked for neoadjuvant therapy also, did they receive or not. And the only confounder that was not balanced enough is the neoadjuvant therapy. So the type of surgery, open or not, it was kind of balanced, and even the type of anastomosis, as is it hand-sewn or stapled. In the case of neoadjuvant therapy, unfortunately, it was not balanced. That's also another limitation which we have discussed about in our discussions. So.
Good.
So congratulations, Shatsi. I would have one question. I had a similar issue, but just for the clarification, if we check the Marty study on this first plot, I see that there are like way more patients in one of the group than in the other. Can you explain what's the reason behind?
Yes, she means the Marty et al. If you can see, they should be randomized controlled trials, meaning that both study groups should have the same amount of patients. In the Marty et al., there's 134 in end-to-end and 65 in the colonic J pouch. There's another bias of ours when we have, well, in a surgical field, I feel like it's very hard to make a good randomized controlled trials because, first of all, obviously the surgeon cannot be blinded, but the other one is the deviation from the intended procedure. This is what's happening with Marty et al. That the randomization happened when the patient was already open and the anastomosis, like the rectum was already resected, and they had to do an anastomosis. So someone opened the envelope and said, "You have to do colony J pouch." Okay, but what we do when we have a male patient, obese, with a very narrow pelvis and a very bulky colon, we cannot do the colonic J pouch. It's impossible to make a colonic J pouch. So these patients were put to the end-to-end. And this is kind of like a quasi-randomized, but there's no other alternative because you cannot compromise it.
So regarding to this first project and the second forest plot where you compare the end-to-end versus side-to-end, you only mentioned the overall result, but I can see two subgroup analysis. What was it based on?
Yes, so the subgroup, we were thinking what to do because some of our articles included sigmoidectomy cases. They were for rectum cancer, but for some reason, they had to dissect more and they had to excise more of the sigma. So they only included 1 or 2 patients like this, so we didn't know what to do. Should we exclude them all together or should we just make a subgroup? But thankfully, we had 3 studies and we could do a subgroup on the sigmoidectomy patients included and also the only rectum resection. But as you can see, it doesn't change the results. So.
Maybe it will be a naive question that since I've been working with surgeons, I've become more interested in what's difficult for them and not just interested in why is G pouch more difficult than an end-to-end anastomosis from a surgical point of view.
Well, end-to-end anastomosis is so easy, especially now in the era of staplers. We have the circular stapler. We just insert it in the anus and then put the I don't know, mushroom part? I don't know in English how you call the...
The right answer is for him, also gastroenterologists can do the anastomosis.
So yeah, it's very straightforward and easy to do, actually. But the pouch requires...
You can use staplers for every time?
Yes. And actually, if it's very low, you cannot do it tension, actually. If it's...
And from the reimbursement point of view, is it financed for every procedure?
It has to be. I mean, it is, yes, because think of narrow pelvis and anastomosis at 4 centimeters. It is virtually, like it's impossible to do tension. Before the circular staplers, I think they didn't resect cancers under 12 centimeters or something, so...
It's a standard to do it with
standard.
stapler. Yeah.
And it's very easy to use.
Thank you for your presentation. I'm a clinical psychologist, so not a doctor, not a medical doctor. So naturally, my question is about the quality of life part of your work. How could it influence or inform the everyday practice of a psychologist? Is there something that you could, like give me as a piece of advice, what I should be more mindful given your results?
So do you mean... because like, is it the first project or second? Are we talking about sphincter preservation or not? Because I feel like when we are preserving the sphincter, we have an easier job with the psychological part of the patient. But when we are talking about removing the sphincter, we need the help of psychologists because it is a very hard it's a very hard thing to accept, to live without an anus, actually. So I think the problem is not related to your work. It's more on the surgeon's side for not sending patients before surgery for psychologists. And I think that should be an important message, that when we are thinking of doing an LAP or abdominoperineal excision, this is a type of surgery that's rarely done in the night shift. So it's something elective. You have time for the patient to go to a psychologist. So I think for you, it is not so much as for the surgeon that we should send these patients to a psychologist. That's all I can say.